Why are we here? Well, we're here to come together and discuss collectively, guide the future of research for the use of active surveillance in the management of prostate cancer. And really, I underline and read collectively here. I mean, this is, I think, the deficit that we hope to address today, that so much work is done in prostate cancer, but sometimes it's done in silos. Sometimes you have work taking place in the patient advocate side, you have work taking place in the academic research side. And the goal is to really push, together as a group, discuss our perspectives and discuss what should be the future of active surveillance research, what should be the priorities that we as a field look forward to investigating and furthering, from the perspective, the shared perspective of all these various parties that are involved and affected. And how are we going to do this? Well, good research starts with a good question. And so by determining the right question to ask, we have made a ton of progress towards then finding meaningful, thoughtful solutions to things that will matter to people. A great quote that I like is, if Albert Einstein, who everyone's familiar with, if I had an hour to solve a problem in my life, depended on the solution, I would spend the first 55 minutes determining the proper question to ask. For once I know the proper question, I could solve the problem in less than 5 minutes. And it really is true. A good, well thought out question just lays the foundation for success. Now, it's worth clarifying what we think of when we're saying research, because research can be a loaded word. And we're not just talking about biomedical research. We're not talking about test tubes and lab research. We're talking about research as it spans the spectrum of the care of the patient. And so every type of analysis can affect and improve the management of prostate cancer patients, especially those that are eligible for active surveillance. We want to touch base on those topics. We want to touch base on social topics and economic topics and environmental topics and psychological topics and cultural topics. We want all of these to be considered. We are figuring out what are the relative merits of various topics and what should we be focusing on as a group going forward. This is a new venture. It may be a new venture for you, and it is certainly a new venture for me and a lot of the people on our team. While we may have participated in things like this in the past, we've never quite done it like this. For it to work, we will need your participation. And I really do mean you, whoever you are, we will need your participation. This is not meant to be a forum where the people who do research on this topic all the time are dominating the conversation. We want to hear from the patients. We want to hear from the family members. We want to hear from everyone, even if you're not used to talking about this. Everyone's opinion here matters equally, and it really is going to be the foundation to success here. So this is a plan for the week, okay? This is a 2-day initiative. We will be working today and Thursday. And today, and in the chat, we'll in just a second share the agenda. It's the same agenda that should have come through the email. So you one way or another, you should have it, but for convenience, we'll share it. But we will set up some foundational knowledge in the first hour, and then we're going to spend most of the day in breakout rooms discussing topics, bring people together, and then we're going to analyze all the information from day one, from Monday, between now and Thursday. And by Thursday, we will review the analysis of today, and we will again meet in breakout rooms to discuss the different kind of topics and questions that came up today and prioritize how important they are relative to each other. And we'll review those results of the group. Ultimately, there will be more output from all of this. There will be papers published. We will make sure we share that information with you and follow up. But this is for the conference in the next 2 days. And so with that, I'm going to hand this over to Mike Ska. Mike has been an absolutely fundamental aspect of this project. Mike is the president and CEO of executive director of Prostate Cancer International. He is a patient advocate extraordinaire. And Mike, why don't you go ahead and give a little bit of the story about the development of this initiative.
Good morning, everyone, and thank you for joining us today. So that everyone is clear about this, I am not a prostate cancer patient. Rather, back in the mid-1990s, for a number of complex reasons, I became an entirely accidental advocate for high quality care for men with and for men at risk for prostate cancer. And because I knew people like Jerry Chodak and Peter Albertson, I very quickly became aware that at least some of those patients did not immediately necessarily need any invasive treatment for their prostate cancer. Next slide, please, Minhaj. The basic idea for the current project grew slowly from a series of events that started in 2016 when I was asked by ASCO to suggest a patient who could talk about the experience of being on active surveillance at the annual Genitourinary Cancer Symposium in 2017. Later in 2017, three other active surveillance patients got together in California and decided to form Active Surveillance Patients International. They did this because they realized that the needs of patients on AS were very different from the needs of patients who got treated for their prostate cancer. The following year, in 2018, again at the Genitourinary Cancers meeting, I asked Dr. Laurie Klotz and others whether they thought the formation of an international working group to collaborate on research that would help to optimize the patient experience of living on active surveillance might be a good idea. To my astonishment, nearly everyone said yes. However, Dr. Klotz also asked with a big smile, "How good are you at herding cats?" It's been a slow process. It's been just under 4 years since I had that initial conversation with Dr. Klotz, and we failed with our first request for a grant to support this meeting. These things happen, and then you try again. Now, I don't want to get into detail about what we do and don't know as of today about how to use active surveillance to manage patients with favorable risk forms of localized prostate cancer. Dr. Parnes is going to do that very soon, and he will do it much better than me. But I do want to make a couple of brief points. First, Dr. Dan Lin in Seattle, who runs the Canary Pass project, very recently wrote that in his opinion, here in the USA alone, at least 75,000 newly diagnosed patients each year are suitable candidates for initial management on active surveillance. But it may be a lot more. And if it's only 40,000 patients a year who actually go on to active surveillance, that adds up very quickly once you start adding the years together. So that's 200,000 patients in the last 5 years. Second, we know that active surveillance works, and it often works really well for some patients. But we desperately need to work out how to apply it better so that we can improve the care, the quality of life, and also the long-term outcomes for all of the patients who are eligible for this management strategy. I want to believe that by all working together, we have a huge opportunity today, but I am realistic about that opportunity, and so I hope that you will be too. I also want to be very clear that there are no bad ideas today. Indeed, the ideas that are off the wall may turn out to be very good ones indeed. Finally, I just want to say that many people have helped to bring this project to life. There's no time today to thank them all individually. They know who they are, and I couldn't possibly have done it without them. So thank you all. And now, if I may, I'd like to introduce Professor Daniel Mullins, who's the director of the Patients Program at the University of Maryland, and who has been integral to this project because he helped to get us the research money. Daniel.
Thanks very much, Mike, and absolute pleasure. For those of you who are new to patient-centered outcomes research and new to hearing about this institute called the Patient-Centered Outcomes Research Institute, or PCORI, it's a real pleasure for me to participate. The Patients Program is really all about listening to patients and community providers and understanding what's important to them, and then bridging between the voices that we hear and researchers who can help to advance the science and treatment of individuals with any condition. Today, we're going to be talking about prostate cancer. And it's been an absolute delight to work with Dr. Siddiqui on this project and the many people who have contributed to date. On the next slide, I just want to give you that overarching picture of what are our goals for today and Thursday, but also what happens after today and Thursday with the dissemination, because we don't want to take what we as a group have brought together today and keep it to ourselves. We want to make sure that this gets out so that every patient, every family member, every community-based provider, every academician, every researcher, and every stakeholder that can help to advance active surveillance being used appropriately knows what we're talking about. So for today, we're bringing together a very diverse group of individuals. Yes, we're bringing together patients and people who are in their families or people who take care of them, either in a medical sense or as a caregiver in the informal sense. We're also bringing together advocates and other people who support networks of individuals who have the condition and those who provide care for them, physicians and other providers, researchers, to develop and then prioritize a list of questions that relate to patient-centered outcomes research. And so the idea is today to come up with what are those questions so that then we can take the many, many good questions that arise and prioritize those that are most important to help individuals with low-risk prostate cancer to make decisions about their treatment options. The broader goal is really to develop these questions in a standard format. You'll hear a little bit more about the Peacocks format of a question, so that in the future, there'll be a research agenda to answer those questions. So again, today it's about coming up with the questions. Thursday, it's about prioritizing them. And then what we hope is that as we disseminate those questions, we can conduct future research that will answer questions that are most important and most relevant to this group. I really want to thank everybody. Again, please actively participate today because every voice matters equally today and in the prioritization process. Thanks, Mike.
Thank you, Daniel. I'd like to introduce Joe Gallo. He's a patient who was recently on AS for 3 years and who is one of the members of the board of directors of Active Surveillance Patients International. Joe?
Good day, everyone. I'm on the board for ASPI, the Active Surveillance Patients International, and I'm also a support group leader with ANCAN, as well as involved in a couple other groups. I just want to give you briefly some background because I am, unlike what Mike said, I am a patient, and I am going to be trying to look at what we're discussing over these next several days from a patient's perspective. One of the advantages of the group that we have pulled together from the patients program that Daniel Mullins has and the PCORI, and by the way, PCORI stands for patient-centered, okay? That's the focus that I'm going to try to take with it and the comments I'll have in a moment. Briefly, my background, I was in Da Nang, Vietnam in 1969 and 70, and exposed to Agent Orange. And Agent Orange, if you're not aware, is a defoliant. The objective was to get rid of all of the dense jungle to be able to then seek out the opponent. That is what has been designated as the cause of my prostate cancer, or the main proponent. Just quickly stated, in 2017, I was diagnosed with Gleason 6, low volume, had a transrectal biopsy and an MP-MRI, confirming it all. 2018, we did the confirmatory, the typical confirmatory follow-up with, again, another transrectal and a MP-MRI, and came up with Gleason 6. During the period of 2019 and 2020, my PSA started to elevate. So the first thing that I did with my doctors is we did another MP-MRI. And again, each of the times came back with a PIRADS-2 saying nothing significant was found. Then we got engaged with the people at the Fox Chase Cancer Center in Philadelphia and undertook a micro ultrasound and a targeted transperineal biopsy, where we found what was probably some working cancer there. And then I had the benefit of being categorized as a Gleason 8, really /9, when it was reviewed by our friend, Dr. Epstein. And then in this year, through this year, I have progressed into treatment, which has included radiation, both brachytherapy, as well as external beam, and on to androgen deprivation. What I've tried to do throughout my time is that try to work closely, not only with for my benefit, but for the benefit of the support groups that I'm involved with, to get intimately involved with the doctors and with the medical staff to try to understand more of what is needed to be able to provide that level of support. One of the things that we're going to hear throughout is that in active surveillance, especially for the newbie, it's a very difficult process to get adjusted. You go through a bit of a shock. I began my own research. I did that from online publications, meetings, etc. As we mentioned earlier, I got involved with ANCAN, ASPE, as well as a couple other support groups, including one group where we're supporting the veterans communication community. What I found was, and what we're going to end up picking up on, and as the prior speakers had mentioned, we are looking for consistency of information, and that's not quite there yet. And that's part of the challenge of being able to do that. And of course, we always have to deal with the knowledge of the fact that I have a cancer, especially when you're newly diagnosed and early on in the process. The one good thing about prostate cancer, the only one that I can think of, is that research and technology is advancing at a very rapid pace, much more quickly than in a lot of other things that are happening in the medical community. Here's the challenge. We have researchers, doctors, clinicians, patients, including partners and caregivers, advocates, and support groups. And we're all trying to do a job. But you know, the challenge is the interaction, the feedback loop. The researchers go on based on what they feel that they know and what they're looking forward to doing next. The doctors, most of them are trying to keep up pretty much with their patients, but the challenge for them is, how do I manage to keep up? How do I stay involved and still manage my practice? Okay, patients, how do I get my answers? Where do I go? Where can I get the good information? I try to get with my doctor, but he answers the questions I ask him, but do I know all the questions to ask? No. And as they come up, it becomes difficult. And of course, advocates and support groups. We're out there trying to do the job, but one of the challenges with support groups is that some of them are really good and some of them need a lot more information. My question here, or my comment here, is that each of these 4 levels need to be able to do a significant amount of interaction. It should be a feedback loop. As things are developed, the awareness needs to be made. As problems are encountered, the same. The doctor who is trying to, doctor or clinician who is trying to manage his practice and manage his patients can't always stay up with, as I mentioned in the prior slide, the rapid developments that are happening in management of prostate cancer. And support groups, we need to be able to get good information to be able to share out. And that is what we're here to do today. That's the challenge. Thank you.
Thank you very much, Joe. I will go ahead and introduce our next speaker. Dr. Tweedy Doe is a program officer for clinical effectiveness and decision science department at the Patient-Centered Outcomes Research Institute. So before joining PCORI, Dr. Doe was at the University of Kansas, where she was responsible for leading and designing, planning, and conducting of independent research projects focused on efficacy of cancer interventions. She also has performed similar work at Fox Chase and Northwestern. She has received her bachelor's from the University of Cincinnati and a PhD from Northwestern. Thank you, Dr. Doe, for taking the time to speak with us. I'm going to go ahead and share her talk up now.
And thank you for the opportunity to speak at the Developing Provocative Questions, the Prostate Cancer Active Surveillance Research Initiative. My name is Tweedy Doe, and I'm a program officer at the Patient-Centered Outcomes Research Institute. I'm delighted to provide a presentation on how to develop a compelling comparative effectiveness research question. Before we start on this topic, I'd like to give you an overview on PCORI and what we do for those who may be less familiar with our organization. PCORI was authorized by Congress in 2010, and we are governed by a 21-member board of governors representing the healthcare community. Our goal is to fund rigorous comparative clinical effectiveness research, or CER, that meaningfully engages patients and other stakeholders and provides answers to real-world questions about what works best for patients based on their specific circumstances and concerns. PCORI's mission is to help people make informed healthcare decisions and to improve healthcare delivery and outcomes. To do this, we seek to fund research guided by patients and other stakeholders that will produce high-integrity, evidence-based information. Our strategic goals are to increase the quantity, quality, and timeliness of useful, trustworthy evidence to inform healthcare decisions, to speed the implementation and use of this evidence, and to influence others' research to be more patient-centered. So what is patient-centered outcomes research? PCORI promotes a special kind of CER called patient-centered outcomes research, or PCOR, and PCOR is CER that focuses on comparing the outcomes that matter most to stakeholders, which include patients, family caregivers, clinicians, patient advocates, and other healthcare stakeholders interested in outcomes that are meaningful to patients. PCORI is interested in funding research that will provide high-quality evidence to help patients, their caregivers, and other stakeholders to make informed decisions. Patients and relevant stakeholders should be meaningfully engaged throughout the research process. Research should also assess outcomes that are important to patients and address the implementation of findings in clinical care environments, so consideration should be given to sustainability of the interventions being compared. PCORI is really unique in that our work is stakeholder-driven. This slide shows how PCORI engages patients and other stakeholders in research, starting from the building of research partnerships and capacity to identifying priorities for research through advisory panels and workshops. We also include patients and stakeholders on our merit review panels to review research applications. We are unique from other funders in that patient-centeredness and stakeholder engagement are two of the 6 merit review criteria on which applications are evaluated. Patients and stakeholders are also engaged during the conduct of PCORI-funded research, as well as the dissemination of research findings. Given this audience's interest in prostate cancer, I would like to note that cancer is the second most studied condition within our portfolio, and as of November 30th of this year, PCORI has funded 12 studies related to prostate cancer, which represents $38.5 million in funding. And now I'd like to transition to a discussion of important considerations when developing a new CER project. When developing a new CER project, it is important to understand the critical choices facing patients, clinicians, and other healthcare stakeholders. Here is where engagement is useful for identifying the healthcare decisions that patients, caregivers, and healthcare providers, as well as other stakeholders, really struggle with because additional evidence is needed. You should also identify the important subgroups that you will focus on. For example, the relevant subgroups might be men, women, racial or ethnic groups, or those with other chronic illnesses. It's also important to recognize healthcare disparities and the reasons for these disparities. Finally, engagement is critical for understanding what outcomes are most important to patients, as they weigh the benefits and harms of clinical alternatives. The foundation of a good CER project is a compelling research question. A compelling research question is informed by engagement of the patients affected by the disease condition and the relevant stakeholders. Engagement should be tailored to achieve this objective. The research question should address a critical decisional dilemma facing patients, clinicians, and other healthcare stakeholders. A dilemma where they are really struggling with deciding among the available clinical choices. The CER question should compare two or more well-justified clinical strategies that have evidence of efficacy. Or if evidence of efficacy is lacking, then there should be evidence of widespread use. Finally, answering the proposed research question should add important new information to the current body of evidence, and this should account for ongoing studies. I would also suggest reviewing the funded studies on the PCORI website to ensure that any studies proposed will complement our portfolio of projects. I'd like to transition now to a discussion of the PCORI methodology standards with a specific focus on the standards for formulating research questions. All PCORI funded studies are expected to adhere to the PCORI methodology standards, which can be found on our website. These standards are the minimal standards for conducting CER and are intended to ensure the scientific rigor of studies. I will highlight some of the considerations discussed in the standards for formulating research questions here. First, a research question should address an important evidence gap, and this gap should ideally be supported by a systematic review. If no systematic review is available, then the methods used to review that literature should be explained and justified. The interventions proposed for comparison should be the actual healthcare options that patients use. We want findings from studies to be useful to patients and for research findings to be taken up and implemented. So that is why it's important that the interventions being compared are realistic healthcare options for patients. The healthcare decision that is going to be studied should be of critical importance to patients, their caregivers, and the relevant healthcare stakeholders. And you should demonstrate a compelling need for additional evidence about the benefits and harms associated with the different options being compared. The specific population for whom this decision is relevant should also be clearly defined. You should be able to describe how the proposed comparators or interventions represent appropriate clinical strategies and allow for direct comparisons. Be cautious about using usual care unless it represents a legitimate and coherent clinical option that can be clearly defined. Once you have identified an important research question, designing a rigorous study that will produce findings to answer this question will be critical. Please refer to the PCORI methodology standards, which include 5 cross-cutting standards for PCOR, as well as additional standards for specific study designs or methods which are applied as necessary. You can schedule a call with a program officer if you have specific questions regarding the submission of a letter of intent or an application. To summarize, the goal of PCOR is to provide trustworthy evidence to inform decision-making for patients, their caregivers, and other healthcare stakeholders when choosing among alternative strategies. An important step towards getting the research question right is to meaningfully engage the patients affected by the condition and other key stakeholders when defining the research question and outcomes that are most important to them. This ensures the research findings will be useful and taken up in practice. Also, the clinical comparisons you propose should be appropriate and well-defined and justified. Finally, please refer to the PCORI methodology standards as a guide for best practices for planning, conducting, and reporting research findings. Thank you for your attention.
Next, I'm going to introduce Howard Parnes. Dr. Howard Parnes graduated from Cornell University with a bachelor's in biology and received his MD from UMD&J, New Jersey. Then he did his residency in internal medicine at Johns Hopkins and a medical oncology fellowship at the University of Maryland, where he was as faculty for 8 years until he ultimately went to the Division of Cancer Prevention at the National Cancer Institute, where he has overseen genitourinary cancer prevention programs since 2001. During this time, he's served on the steering committee for PCPT and SELECT trials, which are two of the larger prostate cancer prevention trials conducted today. He's a board certified physician in internal medicine and medical oncology and continues to see patients within the NCI Clinical Research Center, where he participates in phase 1 and 2 trials and counsels men on newly diagnosed prostate cancer regarding a wide range of management options. But Dr. Parnes is going to give us an overview. He's going to help bring us all kind of on the same page with regards to the history of active surveillance for prostate cancer.
Thanks very much for the opportunity to provide some historical perspective on active surveillance and to try and set the stage for this timely conference addressing unmet research needs regarding localized favorable risk prostate cancer. The introduction of PSA screening in the late 1980s led to a steep increase in prostate cancer incidence by detecting many cancers that would not otherwise have become evident during a man's lifetime. Active surveillance emerged as an attempt to spare men with insignificant prostate cancer from the harms associated with definitive therapy. In contrast to watchful waiting, active surveillance is done with curative intent by monitoring patients with periodic surveillance biopsies to detect disease progression before the window for cure has closed. In 1994, Jonathan Epstein and colleagues at the Johns Hopkins Hospital identified a set of characteristics: biopsy Gleason score less than or equal to 6, 2 or fewer positive biopsy cores, 50% or less involvement of any one core, and a PSA density less than 0.15 that were associated with very small, low-grade cancers at prostatectomy. In other words, with cancers that were likely to be clinically insignificant. In a validation study conducted 10 years later, they found that 92% of patients who met these criteria had organ-confined disease at prostatectomy, 100% had negative margins, and less than 1% had high-grade disease on final pathology. Despite having confirmed and strengthened their original hypothesis, they concluded these criteria also could be used to identify men for whom definitive therapy with its excellent cure rate would be appropriate. But quite presciently, in his accompanying editorial, Eric Klein pointed out that these criteria do identify a subset of patients who may not require immediate therapy. Over the next 10 years, the uptake of active surveillance increased from about 20% to about 50% for patients with low-risk disease. The inflection point for this change in practice was a State of the Science conference held at the NIH in 2011. Following 2 days of presentations and discussions, an independent review panel concluded that active surveillance is a, quote, viable option that should be offered to patients with low-risk prostate cancer. Data from natural history studies, randomized clinical trials, and active surveillance cohorts provided the basis for this assessment. This natural history study done by Peter Albertson in the pre-PSA era demonstrated the relatively indolent nature of untreated low-grade prostate cancer, highlighted here. As you can see, among patients with Gleason 6 or less cancers, death from other causes in light blue was 3 to 5 times greater than death from prostate cancer in dark blue. Albertson also reported on outcomes with conservative management in the PSA era. The low rates of prostate cancer mortality, shown in dark orange, for untreated patients with Gleason 5 to 7 cancers, again shows the relatively indolent nature of low and some intermediate risk disease in most men. The second pillar of evidence in support of active surveillance came from randomized trials showing that definitive therapy was of limited benefit in patients with low-risk prostate cancer. This Scandinavian trial randomized men with relatively advanced localized prostate cancer by today's standards to surgery versus watchful waiting. Only 5% of the cancers had been diagnosed by screening, and 40% were Gleason 7 or higher. In this trial, surgery did reduce prostate cancer mortality compared to watchful waiting in the overall study population. but did not significantly reduce prostate cancer mortality among men with low-risk disease, as shown here. The PIVOT trial compared surgery to watchful waiting in the US. In contrast to the Scandinavian study, 50% of the cancers were PSA detected, and only 25% were Gleason 7 or higher. In addition, a third of the patients were African American. In this trial, surgery did not significantly decrease prostate cancer mortality, likely due to the lower prostate cancer mortality rates in this mostly screened, less advanced population. The PROTECT trial, reported 5 years after the State of the Science meeting, randomized over 1,600 men to surgery, radiation, or active monitoring, a less intensive form of active surveillance. In this trial, all of the cancers were PSA detected, and 23% were Gleason 7 or higher. About 30% of men moved to radical treatment within 5 years, and 45% moved to radical treatment by 10 years. At a median follow-up of 10 years, cancer-specific survival approached 99% for all groups, with no mortality benefit seen for either surgery or radiation compared to active monitoring. Although there were no significant differences in cancer-specific survival, treatment was associated with a significant decrease, 3 to 4% in absolute terms, in metastatic disease, shown here. However, this was at the cost of an increase in patient-reported adverse effects on bladder, bowel, and sexual function, as shown by the blue curves for radiation and the orange curves for surgery. The final pillar of support for active surveillance came from actual experience with this approach in Toronto and at Johns Hopkins. At the time of the State of the Science conference, the Toronto cohort had 450 patients with a cancer-specific survival rate of 98%. Current accrual is now up to 993 men, including 21% with intermediate risk disease, with surveillance biopsies performed every 3 to 4 years. About a quarter of the patients in this cohort discontinued surveillance for definitive therapy during the first 5 years. However, only another 20% came off surveillance over the next 15 years. Nearly half of the men who discontinued surveillance did so for having a short PSA doubling time, and about a third did so for grade progression. Only 6% came off active surveillance due to patient preference. At 20 years of follow-up, 15 patients had died from prostate cancer, and another 15 had developed metastatic disease, for a combined rate of prostate cancer mortality and metastasis of 3%. In contrast to Toronto, the Hopkins active surveillance cohort is limited to men with very low and low-risk prostate cancer, and surveillance biopsies are performed yearly. About a third of patients in this cohort discontinued active surveillance for definitive therapy during the first 5 years. As in Toronto, the discontinuation rate slowed substantially over the next 10 years, suggesting that less intensive monitoring may be appropriate after a successful period of surveillance. As shown in the dotted curves, about 2/3 discontinued surveillance due to an increase in tumor grade to grade group greater than 2 in blue, or less commonly to grade group greater or equal to 3, shown in orange. The remaining third of patients who discontinued active surveillance did so due to increased tumor volume on biopsy. Through 15 years of follow-up, there have been 4 prostate cancer deaths and 1 additional patient with distant metastasis out of more than 1,800 patients, for a combined rate of cancer-specific mortality and metastasis of only 0.1%, shown here in blue. The favorable outcomes for low-risk patients in the natural history studies, the randomized clinical trials, and the active surveillance cohorts are even more remarkable when you consider that a substantial portion of the patients in these studies who were considered to be low risk on the basis of having Gleason 6 cancer would be classified as intermediate risk on the basis of having Gleason 7 cancer today. This is due to 2 factors. The first factor is the modification to the Gleason scoring system that took place in 2005. At the 2005 International Society of Urologic Pathology Consensus Conference on Gleason grading, the rules for determining Gleason score were changed from most common plus second most common patterns to most common plus worst pattern. This meant that before 2005, patients with only small amounts of Gleason pattern 4 were scored as 3 + 3 = 6, whereas after 2005, those same patients would be scored as Gleason 3+4=7. The other factor that needs to be taken into account when attempting to apply the findings of these older studies to a contemporary setting is the tendency of standard prostate biopsies to underestimate Gleason score, a phenomenon known as grade misclassification. The degree to which standard biopsies underestimate tumor grade is shown in this recent series of over 17,000 patients in the UK, in which the rate of upgrading at surgery was 55% among men classified as low risk on biopsy. So you can see that many men classified as low risk in the past would now be classified as intermediate risk due to both the change in the Gleason scoring system and the recent advent of image-guided prostate biopsies, which enhance the detection of small amounts of higher grade disease, thus reducing grade misclassification. Therefore, the favorable outcomes with conservative management of men with low-risk prostate cancer in the past suggest that many men classified as intermediate risk today would also do very well with a surveillance approach. For context, here is a summary of active surveillance cohorts from around the world. Although the vast majority of patients in these cohorts have low-grade prostate cancer, the tendency of standard prostate biopsies to underestimate grade continues to be an issue. Nevertheless, all of these cohorts report 10-year cancer-specific survival of about 99%. We've already seen the reasons for discontinuing active surveillance in the Toronto and Hopkins cohorts. And here is a look at the largest worldwide database showing the reasons for discontinuing active surveillance in over 10,000 men from 12 countries. Overall, about 40% discontinued active surveillance during the first 5 years, about 2/3 of whom did so for disease progression, shown in red, while about 1/3 switched to active treatment without evidence of disease progression, in purple. PRIUS is the largest prospective worldwide study of active surveillance. About half of the men in this cohort discontinued active surveillance by 5 years. About 60% of those who came off active surveillance did so due to biopsy evidence of grade or tumor volume progression, and about 10% came off for anxiety or patient preference, as compared to 6% in the Toronto cohort. Notably, having more than 2 cores on biopsy or a PSA doubling time less than 3 years were not associated with unfavorable pathology at prostatectomy, and these factors were subsequently dropped as triggers for intervention. The PASS cohort is comprised of 905 men, supported by the Canary Foundation, a nonprofit dedicated to the discovery of early detection biomarkers and named for the canaries coal miners once used to detect dangerous gases. At a median follow-up of 28 months, about a quarter of the patients in this active surveillance cohort were reclassified. About 90% of reclassification was due to increased tumor grade, and about 10% due to increased tumor volume. Only about 60% of reclassified patients chose to receive treatment with curative intent, shown in orange, and 50% remained on active surveillance at 10 years. The percentage of positive cores, body mass index, and PSA density were the only baseline factors significantly associated with grade reclassification on multivariate analysis. The Hopkins active surveillance cohort found that the number of positive cores, PSA density, older age, and African American race were all significantly associated with grade reclassification. Regarding age, this analysis from Johns Hopkins revealed that men over 70 had a nearly 4-fold increased risk of progression to grade group 3, that is Gleason score 4+3 or higher, during active surveillance. For this reason, active surveillance may be preferable to watchful waiting in older men with a long life expectancy. Regarding race, African American men are placed on active surveillance less frequently than Caucasians, due in part to concerns that they may harbor undetected high-grade disease. And recent SEER data support that concern by showing significantly more upgrading for low and very low risk African American men, shown in the blue bars, than for Caucasians. This is not the case, however, for favorable intermediate risk disease. Consistent with these findings, Dr. Pinto's group at the NCI found that confirmatory MRI-targeted biopsies upgraded 22.2% of African American men versus only 12.1% of Caucasian men to grade group 3 or higher. However, once qualified for active surveillance by MRI targeted biopsy, the median time to progression, approximately 60 months, was nearly identical in the two groups. Before concluding, I'd like to address the importance of comparative effectiveness and patient-centered outcomes research in providing context for the evolving role of active surveillance in men with localized prostate cancer. The CSER study from the Patient-Centered Outcomes Research Institute compared the effects of surgery, radiation, and active surveillance in more than 2,000 men with localized prostate cancer. With 3 years of follow-up, sexual and urinary function were significantly worse among men treated with surgery, shown in gray, compared to external beam radiation and active surveillance. Men treated with radiation and surveillance were older and had more comorbidities than patients treated with surgery. And as shown here, clinically meaningful declines in sexual function from baseline to 5 years were seen for all treatment groups. However, after controlling for baseline status, active surveillance was associated with significantly better sexual function than either radiation or surgery at 6 months, 1 year, 3 years, and 5 years, shown in orange at each time point. In another analysis of this large prospective cohort, 13% of patients overall reported treatment-related regret at 5 years. Surgery was associated with a 2.4-fold increase in regret compared to active surveillance, and radiation with a 1.5-fold increase in regret that did not quite reach statistical significance. The main drivers of treatment regret were overly optimistic expectations regarding the effectiveness of treatment and the risk of adverse events, underscoring the importance of clear communication when counseling men on the treatment options for localized prostate cancer. So where are we in 2021? Active surveillance has been endorsed by multiple international guidelines as the preferred standard of care for low-risk patients. And the wording adopted by the NCCN in their most recent guidelines, published just 2 weeks ago, is that active surveillance is the preferred option for most patients with low-risk disease. However, substantial variation persists across practice settings regarding how far the boundaries for case selection can safely be pushed, the frequency of surveillance biopsies, and the optimal triggers for intervention. While there continues to be variability with regard to the frequency of PSA, DRE, biopsy, and MRI monitoring, there is now consensus that the trigger for intervention should be biopsy evidence of disease progression or a substantial increase in tumor volume rather than PSA kinetics alone, which often leads to overtreatment. However, the frequency of surveillance biopsies continues to vary substantially across active surveillance cohorts. To this point, a comparative analysis of biopsy frequency based on 4 active surveillance cohorts with different biopsy schedules suggested only marginal improvement for an annual versus an every 3 to 4 year biopsy schedule. And finally, we must acknowledge that active surveillance is not easy. It is expensive, burdensome, and entails the risks of repeated prostate biopsies, as well as the small possibility of missing the window for cure. These factors underscore the need to optimize patient selection, individualize follow-up, and perform patient-centered outcomes and comparative effectiveness research to obtain the data these men need to navigate a complex decision-making process. And perhaps most aligned with my personal research interests as a representative of the NCI's Division of Cancer Prevention is the need to develop therapeutic interventions to prevent the progression of localized prostate cancer in order to make active surveillance feasible and safe for more men. So I'd like to thank you for your attention, and I certainly look forward to hearing a variety of perspectives on these and other issues critical to active surveillance over the course of the conference. Thank you.
So thank you, Dr. Parnes. So what we're going to do now is we are going to have a brief session dealing with a discussion of the Peacocks system. 3 of the speakers you will already have been introduced to. A 4th speaker who will be joining them will be Tony Crispino, who is a patient advocate and has also been the patient author on recent ASCO and AUA guidelines related to the management of localized prostate cancer. Indeed, Tony is also the chairman of the formerly US2 patient support group in Las Vegas, Nevada. Minhaj?
Great. Thank you, Mike. So I will get this panel kicked off. At this point, I'm sure everyone's picking up on a theme. How do I ask a good research question? Okay, so that is what we're here to do in the space of prostate cancer active surveillance. Well, so I mean, yes, it may be true that there's no such thing as a stupid question, but there are certainly questions that are harder to study and other questions that are easier to study. So let's take, for example, a great question, okay? To be or not to be, right? That is the question. And so that one of history's best questions. This is a very hard question to research. There are examples of this, which actually are questions that we ask within the topic that we're interested in. Should we or should we not offer active surveillance to men diagnosed with prostate cancer at an age younger than 60 years old? And this is a good question. This is an important question. This is a question that people are very much interested in. The challenge is that all the various kind of assumptions and perspectives that you bring into this question will lead to the answer being yes, you should, and no, you should not. And both would be very valid kind of decisions. So fortunately for us, there is a methodology, a structure that can help formulate questions that can be effectively studied, okay? And this is called the Peacocks Structure. And really the structure of this conference was built around using this as our backbone to help guide our discussions and guide our flow, if you will. And so Peacocks stands for Population Intervention, Comparison, Outcome, Timing, and Setting. And these are components that a complete research question should be inclusive of. This is all also taking into account the various things that were discussed with Tweedy Doe from Corey and Daniel Mullins and everyone that's been commenting so far. But this is kind of the foundation of it, that we want to have for a given question, the population of interest, the intervention we're looking at, the comparison that we want to compare that intervention against, the outcome that we're studying it up against, the time over which we want to study it, and the setting that it happens. And so let's go back to that question. Should we or should we not offer active surveillance to men diagnosed with prostate cancer at age younger than 60? This is the population aspect, okay? So we actually have the population here, the men younger than 60, and we also have the intervention, active surveillance, but we need to make this a complete Peacocks question. So we want to make this, it's important that everyone kind of understand this topic. We want to make this a little bit interactive. So Daniel, if you could, let's start off with this core, and can you help guide us through formulating this into a more complete, Peacocks formatted question?
Sure, thanks very much. So the first question is, do we want to change the population? Do we want to narrow it down, or do we want to add anything else, right? So we've got a population, but is that too broad? Is it too narrow? So we can start with that. Any thoughts on anything under 60 is enough, or do we want to add something to it? And feel free to send things in the chat. I think we're trying to get open discussion, so you can raise your hand or you can send things to the chat. While you're thinking about that, so do you want to add something more clinical about that? So you're under 60 and or 60, under 60 is enough. The intervention, as Mike said, is pretty, pretty straight. What's the comparator that? Under 60 active surveillance versus what?
So Daniel, maybe we could suggest that it be African Americans under 60, because we know that they're at higher risk. And then the question would be, what is the usual comparator for most African Americans, which surprisingly it seems to be a little unclear and probably depends on different areas of the country as much as anything else.
Okay. And one thing that, especially for projects funded by PCORI that we talk about, is when something's unclear, that's not the best scientific way to proceed, because sometimes if we compare something to, quote, bad care, and and we win, so to speak, then is it clear whether the thing that we're looking at is good or is it just better than bad? And then moreover, if we talk about standard of care, really changes. And that's why it's important to think about the setting. So I think I like your point about saying it's unclear, but then we've got to figure out what is there that's an evidence-based intervention that is an appropriate comparator. And there could be more than one, but I like what you've suggested. A couple of things are coming in the chat. So I think some people are saying, maybe even the age of 60 isn't the right cutoff. Maybe it should be higher, maybe it should be lower. Maybe we want to think about something different. And in the sessions later today, we're going to explore different ones. I see a hand raised. Andrell, if you could help me to call on people with hands raised, that'd be great.
Is that Mark Lichty that whose hand is raised?
Yes.
Okay. Well, I'm even a little uncomfortable with the question, but I'm not sure how to give you feedback because I was diagnosed at the age of 55, and now actually after 16 years on active surveillance, I'm cancer free, and so I think the question should be more open-ended in terms of the age. It depends a lot on whether one is willing to take steps, lifestyle changes, and that's a lot of what Active Surveillance Patients International is trying to emphasize. Lifestyle changes can make a difference. So, I mean, I would have, if somebody hadn't said to me, this is an option, I don't know whether I would have gone on this journey.
Well, thanks. And I think you're pointing out, what we're trying to do is come up with a bunch of questions. So I see in the chat, somebody saying, what about family history? So one question might be for men under the age of 60, or as Mike said, men under the age of 60 who are African-American, and then we have an active surveillance versus appropriate intervention, finish the sentence. Somebody else may say, well, what about getting rid of age altogether and looking at someone with family history? And then eventually, of all of those questions, we can start prioritize them. So I think what we want to do is come up with some good questions and then see of the really good questions, which are the best. And we might, start finding ourselves changing. I see Brian Jarvis has his hand raised. Brian, do you want to go ahead and weigh in on this?
Yes, I kind of see myself in the categories being discussed. One of the comments mentioned, though, was with African-American men, you mentioned healthcare disparities. I'm in the circumstance where I was diagnosed at age 56. I was on active surveillance for 8 years, but I've always had fantastic access to healthcare. So would I be considered differently because I had not faced those disparities and things that relate to those complications that are involved?
That's great. That's great. And yeah, I mean, and I think personal stories always help us to think through what are the important questions. And what I want to say is we're at the top of the hour, we're actually past the top of the hour. So my point is what we're doing right now is what you're going to do as we go into breakout groups. But think about all of those letters in the Peacocks format. And with that, Minhaj, do we want to take one or two more comments from the rest of the panel? Or do we want to move on to the next session?
Yeah, I think then, so the next person in the panel was Tweedy Doe. And my goal was, so I think, we got an example of going through a sample question. And so if we go through this, we would have, and certainly it's a little bit kind of artificial to do this in 2 minutes. This is going to be a prolonged process. But as we come up with like a question of an example, then, Tweedy, how does like PCORI look at these questions and break them apart in terms of understanding that this is a good question, quote unquote?
Thank you, Minhaj. That's a great question to pose. So as I think through each of the Peacocks element, and I think about the question globally, to determine if it's a good question, I ask myself, is this an important evidence gap that has been supported by a systematic review or a professional society guidelines that documents a need for research in this area? The other question I ask myself is there evidence of consultation of patients and key stakeholders on the importance of the research questions and outcomes? And this is because we want your proposed research to be useful to patients and to be taken up in practice. When looking at the population, so the P of the Peacocks, is that population appropriately defined? And Dan did an excellent job running through that, asking, do we need more definition of this population? Is the description too vague? With respect to the I and C, the interventions and comparators, I asked myself, do patients and providers really struggle with a choice between these two or more clinical strategies that you're proposing to compare because there isn't enough evidence to inform a decision? So therefore, is this a compelling decisional dilemma? And that evidence that I ask about, that goes back to the review of the evidence that's available, the systematic reviews that are available. I also ask myself, are the proposed comparisons really appropriate for this target population that you've defined? And do they have equipoise? And like Dan mentioned before, he said, well, if you're comparing one good intervention and a bad one, then you kind of already know what the answer is. So you really want to have two comparators that have equipoise, that there's really no good basis for choosing one intervention versus the other. And therefore you need additional research to provide this evidence. With respect to the O, or the outcome, is the primary outcome of critical importance to patients and key stakeholders, such as clinicians. Is the outcome appropriate and validated for the target population if you're looking at a patient-reported outcome? With the T for timing, is the timing appropriate and is it feasible for the length of the project period? So some examples of consideration when you're thinking about appropriateness of timing is the follow-up period sufficient to detect differences in outcomes between the two study arms? Is there more information needed, for example, on long-term follow-up rather than short-term follow-up? In terms of settings, when you're thinking about settings, are the settings appropriate for the question that you're posing? And will the inclusion of these settings enhance generalizability of study findings? So for example, will you have multiple sites? Are the settings geographically diverse? Do the sites serve patients who are racially and ethnically diverse? So things like that to consider.
Wonderful. And then that was very helpful and very thorough. Thank you. And then lastly, I'm going to hand it off to Tony. And so Tony, you straddle interesting worlds because you are so engaged in the research community, and yet you've maintained, kind of a patient perspective. And so, and that's really what we need here. So as you kind of hear all this and hear this process and hear this structuring, what are your perspectives on what we're doing right now?
This is a great session to develop questions that can be used in research and study. And the purpose to do these researches and these studies is to try to make the experience of active surveillance better among the patient group. If we can develop great questions that can be enhanced and nuanced and brought into clinical trial study, we could actually change practice and change the way people do their experience within active surveillance. I think as we continue to move on along, and I've been watching into the chat, some great questions already coming on in that raise different questions to be asked and put into a research trial or a research study to bring it back and provide adequate answers that people can make good, sound decisions on. And I think that ultimately is what we're all kind of asking. If we're in active surveillance, when is the time that I need to make a change and the way I'm doing active surveillance, the diet, all these fun things and topics that we're going to go on through here today are all going to give us the questions that we're going to go ahead and refine. We're going to form them into Peacocks questions with which can be moved forward for further research. And I think it's important that all patients understand you're playing a role in your future here.
Awesome. Thank you. That's really great. And I think that is key to remember what our goals are and really, again, the importance everyone on this meeting has in influencing that. So today's task is that we will discuss various interesting topics. Just like we started this session with the topic of men younger than 60, and then we started probing into the various other components of what that means to study that general topic. We want to do that in these different sessions, and we will use this Peacocks structure to focus our discussion. This summer, as building up to this project, we actually circulated a list of 41 interesting topics, okay? And we actually had people vote on it. We had both patient community and academic community vote. We had 265 respondents. Many of the people in this room probably took this survey a few months ago. And then we characterized those topics by the Peacocks categories, and we picked 4 to focus on: population, intervention, outcome, and setting. So these will be the 4 sessions today. And we picked the top 4 voted categories in each group as our discussion topics. When you registered a preference for these groups. And so today you will be assigned into one of 4 breakout rooms for each session. And as a warning, we have a backbone team here who's working very hard to do this, but it is a bit of a logistics challenge to kind of get everyone efficiently moved in. So we will, let's see how this goes. But essentially, population, the session 1 that's going to come up now is population, and the 4 topics that'll be discussed is, one is what we just said, men younger than 60 years old. We'll also be talking about men with favorable intermediate risk prostate cancer, men with high risk family history of prostate cancer, and African American men, and so on and so forth. And each session will be introduced by a moderator pair. So I'm not going to cover all these right now. The breakout room facilitators are 4 people: Arvin George, who's an assistant professor at the University of Michigan; Kara Watts, who's an associate professor at Albert Einstein College of Medicine; Christian Pavlich, who is a professor at Johns Hopkins; and Sinoj Punin, who is an associate professor at the University of Miami. All 4 of these are urologists specialized in urologic cancer who have a strong backbone of knowledge and experience, and can help kind of guide the room. But ultimately, they are meant to be facilitators in the true sense of the word. What we really want to hear is your voice. So to introduce session 1, I will hand it off to Jimmy Slade and Sam Washington. Retired Colonel Jimmy Slade is an executive director for the Community Ministry of Prince George's County CPMG, which is a 40-year-old faith-based nonprofit organization and seeks to help meet the human service needs, close the education gap, and reduce health disparities of underserved communities. He has done amazing work in providing avenues for infrastructure and outreach to the underserved and under-resourced communities in his region. And Sam Washington is a highly accomplished urologist and assistant professor of urology at the University of California, San Francisco, where he holds the Goldberg Benioff Endowed Professorship in Cancer Biology. Dr. Washington completed his undergraduate studies at UC Davis and Bachelor's of Science in Genetics and a minor in Latin. He also completed his medical school training at UCSF, where he stayed on for residency and fellowship. His research focuses on prostate cancer outcomes, with the current research focus on health services and cancer outcome disparities. Jimmy and Sam.
Good afternoon. I'm Jimmy L. Slade. I'm the Colonel retired U.S. Army. After retiring from the U.S. Army as a career intelligence officer, starting in 2010, I was fortunate enough to work with University of Maryland, Professor Cheryl Knott, who's on this call, in developing and implementing 3 R01 level studies or projects that each included prostate health and prostate cancer as part of that. At the same time, I was also involved with another 4th study with Johns Hopkins, similar on prostate cancer in older adults. Over the last 18 months, I've led and continue to lead a prostate health program that spans the continuum from prevention, education through professional support. And I really like this conference and what we're doing, because as a career intelligence officer, I appreciate the focus of the conference on formulation of questions, as it is quality formed questions that also drive the U.S. intelligence. And so I look forward to working with our esteemed colleague, Dr. Washington, who I just met in the chat, and I'll be followed by him, please.
Thank you, sir. Sam Washington, Urologic Oncologist at UCSF. Thanks for having me. I'm excited and looking forward to this because particularly within prostate cancer, we have a wealth of documentation of things happening, particularly for men under the age of 60, different racial groups. But when it comes to why, or even differences within racial groups, you see a dramatic decrease in the amount of literature and knowledge that we have. And I think that's mirrored by a lot of the questions that we saw in the chat. African-American men diagnosed early who have great access to care. We've always treated these as independent factors, but we know in the real world, all of these things are coming together. And we have no idea what that person's risk is, or my risk, for example, compared to a person where I grew up who has no access to care. And the fact that we can't tease that out tells us we need a conference like this to get deeper into those questions, because we're limited by the data we have available to us right now. So I'm looking forward and excited to participate in this, and great to talk to everyone. And for our groups, as you know, they were outlined already. We'll have these 4 groups, and we'll be able to break into these breakout rooms and discuss these further.
Wonderful, thank you. So let's go ahead and break into our rooms.